Welcome to Biochem Doctors. And this week we'll be focusing on diabetes. With myself, Dr. Amira Bisessa, Dr. Sally Arjun, Dr. Omar Ali, Dr. Amanda Arjun, and Dr. Pooja Nuki.
To get this show started, we have a very special guest live on air with us. We have Dr. Claude Can. Dr. Can is a diabetologist. He is currently the #1 clinician in Trinidad and Tobago. He is the president of the Diabetes Clinicians of Trinidad and Tobago, and he's a community diabetologist for the Southwest Regional Health Authority. In addition to that, he is also a doctor at the Anaposis Center for Diabetes Treatment. So, let's go over to Dr. Claude Can.
We need to talk about the role of the insulin and glucagon in somebody who's not diabetic. We know that glucose is liberated from dietary carbohydrates that we eat, such as starch, sucrose, and these are hydrolyzed in the intestine and then absorbed in the blood. When you have elevated concentrations of blood glucose, you have insulin being released from the beta cells in the pancreas, and this is a normal mechanism, and the action of insulin allows glucose to be taken up and utilized within the cells. Now, you have the role of insulin on the skeletal muscle, adipose tissue, as well as the liver. And there's a receptor called GLUT4, G-L-U-T, GLUT4, that is a hexose transporter. And this is an essential receptor on muscle sites, on adipose tissue, that allows insulin to have its action within the cells. You have binding of the insulin on the receptor sites, and this will lead to a rapid transfusion of those vesicles with plasma membrane and insertion of the glucose transporters, thereby giving the cell an ability to take up glucose. Another important site of action for insulin is the liver. So insulin has several effects in the liver, which stimulate glycogen synthesis. In diabetes mellitus, and of course we know there are two types of diabetes. Basically there's type 1 diabetes and type 2 diabetes. In type 1 diabetes there is an autoimmune process that leads to the destruction of the beta cells, and although a lot of research has gone into the trigger factors for type 1 diabetes, we're still not sure what actually causes type 1 diabetes. There's sometimes a family history, but some of the thoughts are it could be a viral mechanism, or it could be a stress-related factor that lead to an autoimmune process that destroy the beta cells of the pancreas. So in type 1 diabetes, the pancreas is unable to produce any insulin, and then in type 2 diabetes, in the early stages, you have hyperinsulinemia, and you have insulin resistance. So the beta cells are pumping out insulin into the bloodstream, trying to keep the blood sugar levels normal, and the body's not responding. And the reasons for that are often genetic. We know that there are some family lines that the GLUT4 receptors are not present in sufficient amounts, so the body is not able to respond to the action of insulin. And eventually you get to a point where the beta cells begin to decompensate and insulin levels begin to fall, and that's when we diagnose type 2 diabetes. So in type 2 diabetes itself, we have insulin levels falling. So as a result of that, you don't have enough circulating insulin, so not enough insulin to allow blood glucose to go from the bloodstream into the muscle and adipose tissue. And also remember that insulin is responsible for glycogen synthesis in the liver. So you have someone eating and the body is not able to utilize that glucose to build up glycogen, and all that blood glucose then the glucose stays in the bloodstream. Glucagon has a major role in maintaining normal concentrations of glucose in the blood. And it's often described as having the opposite effect to insulin. So the effect of glucagon is increasing the blood sugar levels. And what has been recently realized, glucagon is also a big player in type 2 diabetes. But we now realize that the alpha cells of the pancreas overproduce glucagon in type 2 diabetes. You have insulin deficiency as well as hypersecretion of glucagon. Glucagon is a linear peptide of 29 amino acids, and it's synthesized first as pro-glucagon, and then it is broken down to yield glucagon within the alpha cells of the pancreas islets. So the major effect of glucagon is to stimulate an increase in the blood concentration of glucose. So, for example, in the starving state, what will happen is that your insulin levels are very low and the alpha cells kick in, glucagon is secreted, and the glucagon then has an effect on the hepatocytes, activate enzymes that depolymerize glycogen and release glucose. Glucagon also activates hepatic gluconeogenesis. So what is gluconeogenesis? It's a pathway by which non-hexose substrates acids are converted into glucose, and it gives you glucose within the bloodstream. Remember that the brain in particular cannot survive without glucose. So in disease states, we have excessively high or low secretion of glucagon, which is type 2 diabetes, as we are saying. We now understand that it's not just a state of insulin deficiency, it's also a state of glucagon excess. In type 1 diabetes, there's also evidence that there's an aberrant secretion of glucagon, and it contributes to the metabolic derangements seen in type 1 diabetes. Thank you very much.
Let's look at the pathways in which diabetes affects.
How exactly does insulin and glucagon affect the body? Well, they do so by altering the biochemical or metabolic pathways. Both insulin and glucagon affect three main organs: the liver, the muscle, and the adipose tissue. Insulin increases the following metabolic pathways by activating the most regulated enzymes as seen on the screen. In type 1 diabetes, where there is a reduction in the amount of insulin, we also see a reduction in each of these activities. In insulin intolerance of type 2 diabetes, we see a reduction in glucose uptake in muscles and adipose tissue, but an increase in uptake in the liver. This is because the liver possesses GLUT2 or insulin-independent glucose transporters. It should also be noted that insulin also decreases these pathways. Glucagon, on the other hand, increases these metabolic pathways, which are somewhat like the opposite of the pathways that insulin activated. Therefore, it decreases the pathways that insulin would have activated, such as the following:
the reciprocal regulation of glycolysis and gluconeogenesis. Reciprocal regulation prevents activity of two closely paralleled pathways. We do not want the liver to degrade glucose via glycolysis, only again to make through gluconeogenesis. This would lead to a futile cycle, which would waste ATP, and remember, it is important for all organisms to conserve as much energy as possible. When there is an excess of energy, gluconeogenesis is inhibited. When energy is required, gluconeogenesis is activated in the liver to produce glucose to send into the blood to return blood glucose levels. This occurs after glycogen stores have been depleted. The conversion of fructose 1,6-bisphosphate to fructose 6-phosphate with the use of fructose 1,6-bisphosphatase is negatively regulated and inhibited by the molecules AMP and fructose 2,6-bisphosphatase. There are reciprocal regulators to the enzyme called phosphofructokinase 1. Phosphofructokinase 1, or PFK1, is a key regulatory enzyme of glycolysis and is insulin dependently activated. When insulin is present, other enzymes called phosphodiesterase degrades the phosphodiester bond in the second messenger molecule, CAMP. The result is higher levels of fructose 2,6-bisphosphate, which leads to an increase in activity of phosphofructokinase 1 and deactivates fructose 1,6-bisphosphatase so that glycolysis is favored. When energy levels are low, such as during the fasting stage, glucagon is produced. This raises the levels of CAMP. Thus, protein kinase A inactivates phosphofructokinase 2. The fructose 2,6-bisphosphotase is then activated, which lowers fructose 2,6-bisphosphate levels. Because fructose 2,6-bisphosphate normally stimulates phosphofructokinase 1, the decrease in its concentration leads to an increase in fructose 1,6-bisphosphatase and thus the inhibition of glycolysis and the stimulation of gluconeogenesis. In type 2 and type 1 diabetes, there is a reduction in glycolysis due to insulin resistance to the body and a lack of insulin production, respectively. This occurs because insulin doesn't work properly. Thus, cells cannot take in glucose from the blood and they begin to think that they are starving. As such, there is an increase in gluconeogenesis, despite glucose already present in the blood, thus further increasing blood glucose levels after glycogen stores have been used.
The reciprocal regulation of glycogen degradation and glycogen synthesis. Glycogen is a very important compound within liver cells and muscle cells. In liver cells, glycogen is used to retain blood glucose levels before gluconeogenesis takes place. However, in skeletal muscle, glycogen is used as an energy store. Glycogen synthesis and degradation responds to insulin and glucagon respectively. These are both secreted from the pancreas, insulin from the beta cells and glucagon from the alpha cells in response to the blood glucose levels. In order to avoid a futile cycle of glycogen synthesis and breakdown, simultaneously regulation occurs on the enzymes glycogen phosphorylase and glycogen synthase. Glycogen phosphorylase is regulated by both allosteric factors and by phosphorylation. Its regulation is consistent with the energy needs of the cell. High-energy substrates ATP, glucose 6-phosphate, and glucose inhibit glycogen phosphorylase, while low-energy substrates such as CAMP and glucagon activate it. In the liver, glucagon activates AMP to CAMP, which promotes phosphorylation of protein kinase to its A or active form. Protein kinase A phosphorylase kinase to its active form, glycogen phosphorylase kinase A. Then glycogen phosphorylase kinase A finally adds a phosphate group to glycogen phosphorylase to form glycogen phosphorylase A, or the active form of the enzyme, which breaks down the glycogen to glucose 1-phosphate, which is then converted to glucose 6-phosphate. Glucose 6-phosphate is then converted to glucose by glucose 6-phosphatase and then enters the blood. CAMP also phosphorylates glycogen synthase to its B form, thus making it inactive and stopping glycogen synthesis so that glycogen breakdown can take place.
In muscle cells, muscle contraction promotes glycogen breakdown by releasing calcium, which bind to calmodulin subunits for phosphorylase kinase, thus activating it. This then goes on to activate glycogen phosphorylase, which breaks down the glycogen to glucose 6-phosphate, and since muscle do not have glucose 6-phosphatase, when glucose 6-phosphate is produced, it enters glycolysis directly. However, when insulin is present along with high levels of glucose 6-phosphates, if the cells have enough energy and do not require ribulose, then glycogen synthesis takes place. Insulin promotes the opposite to glucagon by activating of protein phosphatase 1, which removes the phosphate group from glycogen phosphorylase kinase and glycogen phosphorylase, making them inactive, thus stopping glycogen breakdown. Protein phosphatase 1 also dephosphorylates glycogen synthase to glycogen synthase A, and so glycogen synthesis restarts. In muscles, at a state of rest, calcium production stops, and so phosphorylase kinase and glycogen phosphorylase activity also stops. Because of abnormal amounts of insulin, liver glycogen can be abnormally accumulated or depleted. Restoration of normal glucose metabolism usually normalizes glycogen metabolism. In patients with type 2 diabetes, glycogen storage is low in muscles due to impairments in insulin-stimulated glycogen synthesis and the action of protein phosphatase 1. In prediabetes or in hyperinsulinemia, where there is an increase in the amount of insulin in the blood, glycogen accumulates and glycogen degradation is inhibited.
Welcome back to the studio. I'm here with my colleague colleague, Dr. Amanda, and we heard all about diabetes from Dr. Claude Can, and we also heard about the effects on the pathways. Now, we're here to find out how diabetes affects the body. We have two special guests. We're here in the studio to hear about their struggles and trials with this disease. Let's hear their story.
The story starts 15 years ago. Mr. Ali, a farmer at that time, went to his garden to tend to his crops. While raking the grass, he had a hypoglycemic attack, which resulted in a short blackout. While falling, he hit his foot against a rock, causing a cut. He mustered up enough strength to drag himself home, where his wife Mavis attended to him. After weeks of the cut not healing, Mr. Ali decided to consult a doctor. She examined the cut, treated it, and questioned Mr. Ali. Her diagnosis was that perhaps Mr. Ali had diabetes. Upon testing his blood glucose, the diagnosis was confirmed. She then explained to Mr. Ali his condition and the changes within his life that had to be made. She also explained treatment options, and since that day, Mr. Ali's life has drastically changed.
So what symptoms do you suffer from?
Well, as you can see, my foot is swollen.
This is
I'm getting real trouble seeing and all. Look at it. I can't see properly.
I need to help him walk. He can't do anything. We all know this is an effect of diabetes because
Mavis, should I tell you?
no, you can't see that on TV.
We
What
have
is
sexual
this?
problems. I don't perform as I used to.
Do you want to elaborate?
So are you saying that you're impotent?
Well, if it's, that is probably scientific term for it, but I'm not sure.
We're so sorry to hear about all your problems, but again, I want to thank you for coming on your show and being so sincere and intimate about your disease. I wish you all the best. We have seen the effects of diabetes on the body, and you've seen the pathways that are affected. So I hope this episode of Biochem Doctors was useful in clarifying some of your questions about diabetes. Please join us next time.
Thank you for watching.